Alright everyone, we are back. This is Ahmed Radwan and we are getting back to dermatology. We have stopped at the sexually transmitted disease section. We finished the viral infections and now we are going into the STDs. We took a 10-minute break and we should be refreshed. And we are trying to finish dermatology actually in this Pomodoro or this 25-minute. So let's do it. All right. So first off, with the sexually transmitted disease is the very famous human papillomavirus. Warts, it says here, that are caused by human papillomavirus or condyloma acuminata present as heaped up, translucent, white or flesh-colored lesions on mucous surfaces. How are we going to diagnose such a thing? Well, there is no form of testing is routinely necessary to be done. Biopsy, scraping, smears, and serology are of no definitive benefit here. So there is no benefit of routine subtyping of the specific strain as well as the papillomavirus. So really here, no diagnostic testing, I guess. Okay. All right, so if we have diagnosed it basically clinically, how are we going to treat it? First, it's the mechanical removal. The mechanical removal, this can involve cryotherapy with liquid nitrogen, very famous. Laser removal can actually be done as well. Trichloroacetic acid or podophyllin to melt them away. We can use all these. Imiquimod is a local immunostimulant. It can that takes several weeks to result in sloughing off of the wart. Resolution here is slower, however. There is never any damage to the surrounding normal tissue, which is really good, and no pain as well, which is really good. And then finally we have podophyllin. It's potentially teratogenic here, and it should be scrupulously. Okay, it should be avoided in pregnancy. That's the most important part here. Okay, so what we got here is either mechanical removal or imiquimod, which takes longer time. And if we're going to use a podophyllin, it's potentially teratogenic, so do not use it in pregnancy. All right. So now we're done with the human papillomavirus. Let's go to the second most famous STD here, which is the syphilis here. Syphilis, it's both either primary or secondary syphilis. It presents mainly with the cutaneous disorder. The primary syphilis, we have the chancre, which the primary lesion here for primary syphilis is an ulceration with a heaped up indurated edges that is painless. That's very important. Painless. The best initial test is the dark field examination. This is because there is a false negative rate of 25% for both the VDRL and the RPR, so that's why the dark field examination is the best initial test. I think that would be a common mistake to say the VDRL or RPR. In other words, these serologic tests need several weeks to become positive, and they are only 75% sensitive in the primary syphilis. So. Both primary and secondary syphilis are treated with a single intramuscular dose of penicillin. Really easy to do here. In those patients allergic to penicillin, however, we can use doxycycline orally for 2 weeks as an alternative. All right, so that's primary syphilis. How about secondary? Well, secondary syphilis, it presents with a generalized copper-colored maculopapular rash that is particularly intense on the palms and soles of the feet. I remember from step 1, actually, there were 3 diseases that has the palm and soles. I think it has the Rocky Mountain spotted fever, maybe, and the syphilis, and another thing. I think Coxsackie virus, maybe. I'm not really sure, but what I remember exactly is that secondary syphilis, the palms and the soles. The other manifestations of secondary syphilis are predominantly dermatologic as well, like the mucus patches, the alopecia areata, and the condyloma lata. The VDRL and the RPR tests have nearly 100% sensitivity in secondary syphilis, so we can use it here. As above, both primary and secondary syphilis are treated with a single intramuscular dose of penicillin again. And those patients allergic to penicillin use what? We use doxycycline for or 2 weeks orally. All right? Okay. Now we're done with syphilis and the human papillomavirus. We're done with the sexually transmitted disease here, at least the important part. Now we go on to parasites, which are scabies and pediculosis. Scabies involves primarily the web spaces of the hands and the feet, very famous, but it can also cause periodic lesions around the penis, the breasts, and so on. Itching can be extreme in both cases, actually, because Sarcoptes scabii, which is the organism here, it's quite small, and all that can be seen with the naked eye are the burrows or the lines that you see on the skin, and the excretions around small periodic vesicles as well. So you can't really see them that much. Scabies here, as a side note, often spares the head. So if somebody is scraping his head, usually it's not scabies. All right. Immunocompromised patients, such as those with HIV, are particularly vulnerable to an extremely exuberant form of scabies with severe crusting known as the Norwegian scabies. I don't know why they call it that way, actually. But anyways, that's for the HIV or the immunocompromised patients here. The diagnostic testing that we need to do for scabies is confirmed by scraping out the organism after mineral oil is applied to a burrow, so we can view it under the microscope. We treat it with the permethrin. Lindale has equal efficacy but greater toxicity. Thus, it is not the best initial therapy. So the best initial therapy is permethrin. Scabies, particularly the Norwegian type, can be treated with the ivermectin orally as well. Okay? So again, best initial is the permethrin, and it could also be treated with ivermectin orally. Okay, done with scabies, let's look at pediculosis, which is lice and crabs. Pediculosis tends to include the head here, so that's a differentiating feature between scabies and pediculosis, and is easily transmitted by sharing hats and hairbrushes. Both organisms have an enormously high rate of transmission through sexual contact as well, with 90% transmission from a single contact. There are sometimes rust colored from their ingestion of blood. Okay. The diagnostic testing here, because pediculosis is caused by a much larger organism, scraping is not really necessary. The organism can readily be seen attached to the hair-bearing areas, particularly under the magnification. So we can either take a look right away, or we can have it under the microscope. Alright. Okay. Now for the treatment. How we're going to treat it? As with the scabies here, the treatment is permethrin. Lindale has equal efficacy again, but greater toxicity, thus it's not the best initial therapy. And pediculosis can be treated with over-the-counter pyrethrins. Okay, so permethrin for both scabies and pediculosis again here. Lindale can be used, but it's not the best initial therapy. Okay, now we have Lyme disease. More than 85% of patients who have Lyme disease will develop rash. I think it's a really distinctive rash. The rash must be erythematous with a central clearing, so it's kind of like a target rash, but the central clearing instead of the redness in the center, and be at least 5 centimeter in diameter. Okay, so 5 centimeter in diameter, central clearing, erythematous rash. Usually occurs 7 to 10 days after the tick bite, so it's not right away. It takes some time, so we have to take a detailed history if there has been a tick bite or any travel or anything like that. This rash is so characteristic of Lyme disease that it is more important than serologic testing as well, actually, which is in terms of confirming diagnosis. If the rash is described, then go straight to therapy. Right away. Do not wait for any serologic testing. How are we going to treat it? We treat it with oral doxycycline, amoxicillin, or cefuroxime. Right. What if there is no therapy, or what would happen as a complication of no therapy? Well, two-thirds of these patients will develop joint disease, and a smaller number will develop neurological or even cardiac disorders as well. Okay? All right. Most importantly, just remember the rash, erythematous, and central clearing in the middle. All right. Okay. Now we are having something called the toxic mediated disease. We talked about that earlier, like the toxic shock syndrome and the staphylococcus skin, scalded skin syndrome as well. And we are gonna mention as well anthrax. So those are the three things we are going to talk about in the toxic mediated diseases. Okay, so first off, the toxic shock syndrome. Toxic shock syndrome is caused by staph, and it's Staphylococcus attached to a foreign body. A nasal packing, retained sutures, or any other form of surgical material retained in the body can promote the growth of any type of staph, and that produces the toxin. So look for a patient who has a foreign body. Nasal packing, as we said, sutures, surgical materials, anything like that. How are we going to diagnose it? Because there is no single specific test here, cases are matters of definition. The definition of a case of toxic shock syndrome is that a fever of more than 102 Fahrenheit, a systolic blood pressure of less than 90, desquamative rash, so desquamation of the skin, vomiting, and involvement of the mucous membrane of the eye, mouth, and genitals. So again, we have we have fever of more than 102, systolic blood pressure less than 90, and a desquamative rash, vomiting, involvement of the mucous membrane of the eye, the mouth, and genital. In addition, the toxic shock is a systemic disease that raises the creatinine, the CPK, and the liver function tests. It lowers the platelet count, and it can cause central nervous system dysfunction, such as confusion. So we actually can diagnose it from that. We don't have a specific test that we can do. Well, if we think that the patient has a toxic shock syndrome, how are we going to treat it? First, and most importantly, is the vigorous fluid resuscitation. We can also use pressors such as dopamine. Then we can use anti-staph medications such as oxacillin, acicillin, and cefazolin. And if there is for a methicillin, or the oxacillin-resistant strains, we use vancomycin or the linezolid can be used. Okay, so IV fluids, pressors such as dopamine, anti-staph, and if it's MRSA, then we use vancomycin or linezolid. How about the Staphylococcus scalded skin syndrome? Well, the 4S, or the Staphylococcus scalded skin syndrome, is mediated by a toxin from the Staphylococcus as well. It presents with the loss of the superficial layers of the epidermis and sheets, and Nikolsky sign. If we can remember, Nikolsky sign is with minimal pressure, the skin just sloughs off. We had that with the first disease that we talked about, which is the what was it again? I'm sorry, just a second. Yes, it was the pemphigus vulgaris. We had that Nikolsky sign. All right, okay. The scalded skin syndrome differs from other conditions as follows. So unlike the toxic shock syndrome, it presents with normal blood pressure, so there is no involvement of the pressure at all. Also, there is no involvement of the liver, the kidney, the bone marrow, or any central nervous system manifestations as well. And unlike the toxic epidermal necrolysis, which results from drug toxicity, it is caused by an infection. In addition, it only splits off the superficial granular layer of the skin and not the full thickness split, such as in toxic epidermal necrolysis. So we can differentiate between these two as well. Finally, the condition, it should be managed in a burn unit. We give oxacillin, acicillin, or other anti-staph antibiotics in that case. Okay, and finally, we're going to talk about anthrax. Bacillus anthrax. Anthracis is usually a cutaneous infection acquired from contact with the infected livestock. It is an occupational hazard of wool sorters. So if we have someone who is working as a wool sorter, he sorts wool and stuff like that, it can be a problem for him. The bioterrorism is also a potential source, but I highly doubt that we're gonna have a question just saying bioterrorism right away. It's gonna be hidden a little bit more. Um, it's gonna be presented as a papule that appears on the skin that later becomes inflamed and develops a central necrosis that is black in color. So central necrosis, black in color. Think of anthrax. Hence the name anthrax. Okay, and anthrax just means in the Greek word was cold, and that's referring to the black color. Of the untreated cases, 20% are fatal, so it's relatively a dangerous disease. We can diagnose the disease with just the clinical picture here, but it can be confirmed with a gram stain and culture of the lesion. We can see the Bacillus anthracis, and we should be treated with the ciprofloxacin, floxacin, or doxycycline is the primary treatment here. All right, okay. Now we're done with the toxin-mediated diseases here. Now we can talk about the malignant and the pre-malignant diseases. We are generally gonna talk about the benign lesions that we can anticipate. We're going to talk about melanoma, seborrheic keratosis, actinic keratosis, squamous cell carcinoma, basal cell carcinoma, Kaposisarcoma, and so on. So that's the malignant and pre-malignant diseases that we are going to cover. All right. Let's start with the benign lesions here. Well, the predominant method of distinguishing between benign and malignant lesions is the shape and color of the lesion. So that's the first thing we look at. With benign lesions such as the junctional or intradermal nevus, they are characterized by specific things. First, they do not grow in size. That's very important. They have smooth, regular borders. There is usually less than 1 centimeter in diameter, and they are homogeneous in color, and the color remains constant all the time. So, not grow in size, regular border, smooth, diameter is less than 1 centimeter, and they are homogeneous in color, do not change color. Biopsy is the most accurate method, of course, of the diagnosis. Benign lesions only need to be removed for cosmetic purposes only. So, that is just very clear. Second, we're going to talk about the non-benign or the malignant lesions here. First, we're going to talk about melanoma. Well, these malignant lesions, they grow in size, so that's very important. They have irregular borders, and they have uneven shape and have inconsistent coloring. We do the biopsy, and this is the best test to be used. It should be done with a full thickness sample. Because tumor thickness is by far the most important prognostic factor. So the most important prognostic factor in melanoma is the tumor thickness. So not the size, thickness. Okay, how we're going to treat it? Well, melanoma is it's going to be treated by excision. We can use interferon as it seems to reduce the recurrence rate of melanoma here. All right. Second, we're gonna take a look at the seborrheic keratosis. I'm not sure if I'm saying it right. Seborrheic keratosis. All right. This is a benign condition with hyperpigmented lesions occurring in the elderly with a stuck-on appearance. So again, they are benign, but it looks as hyperpigmented lesions, and they occur in the elderly with a stuck-on appearance. They are most common on the face, shoulders, chest, and back. We cannot remove it with liquid nitrogen or curettage, only for cosmetic purposes again. They don't have any malignant potential. There is no relationship to either actinic keratosis or seborrheic dermatitis at all. That's just a different name. Okay. Third, we're gonna talk about the actinic keratosis. Actinic keratosis, they are precancers, so that's just different. It's different from seborrheic keratosis. Actinic keratosis is precancerous. They occur on the sun-exposed areas of the body in the older person. As a comparison, they are the seborrheic keratosis in the face, shoulders, and chest and back. They occur most often in those with light skin color. So think of someone who's white. Although they are usually asymptomatic, they can be tender to the touch. Well, therapy is universally with sunscreen to prevent their progression and recurrence. Lesions should be removed with cryotherapy. We can have topical 5-fluorouracil as well, imiquimod, topical retinoic acid derivatives, or even curettage. So many things that we can use to remove it. But basically, it's very important to use sunscreen to prevent progression. All right. Now we have squamous cell carcinoma and basal cell carcinoma. I'm going to try to differentiate between these two. First, squamous cell carcinoma. Of all skin cancers, 10 to 25% are squamous cell, and 65 to 80% are basal cell cancer. So basal cell is more present than squamous cell carcinoma. Squamous cell carcinoma develops on the sun-exposed skin surface in the elderly patients, so we can expect it to be in someone who is old and in a sun-exposed area. It is particularly common on the lip. You can see it on the lip. So if we see a potentially malignant lesion on the lip, it's usually squamous cell carcinoma. So, as we said, on the lip, where the carcinogenic potential of tobacco is multiplicative. So, someone who is smoking, who is elderly, who is having a lesion on the lip, we should think about squamous cell carcinoma. Ulceration of the lesion is common as well. Metastasis is rare, and with only 3 to 7% of patients developing actually them. We diagnose it with a biopsy, and the treatment is surgical removal, of course. All right. Now let's take a look at the basal cell carcinoma here. Well, of all skin cancer, as we said before, 65 to 80% is basal cell carcinoma. It has a shiny or pearly appearance, and the metastasis is less than 0.1%. So that's just really rare. The diagnosis, it's confirmed by shave or punch biopsy. We treat it with surgical removal, and there's something called Basal microsurgery that has the greatest cure rate. In this technique, instant frozen sections are done to determine when enough tissue has been removed to give a clean margin. So we just do the surgery and take a frozen section and see how it goes. Alright, so that was basal cell carcinoma and squamous cell carcinoma. Okay, and now let's talk about the final malignant disease here, which is the Kaposisarcoma. Well, Kaposisarcoma are purplish lesions. They are found on the skin, predominantly in patients with HIV, of course, and CD count of less than 100. Human herpes virus 8 is the causative organism. The best therapy is to start antiretroviral therapy. Oh, so that's the best therapy, is to start the antiretroviral and raise the CD4 count. So it's not really, so it's not really to treat the human herpes here. It's to start the antiretroviral therapy. Okay. All right. And those in whom this does not occur, the specific chemotherapy for Kaposisarcoma is liposomal adriamycin and vinblastine. Okay, again, those in whom this does not occur, the specific chemotherapy for Kaposisarcoma is liposomal adriamycin and vinblastine. So we use adriamycin and vinblastine for Kaposisarcoma as a chemotherapy. Alright, so we still have 3 pages here of dermatology. We're going to take a break for 5 minutes and then get back to it right away. Alright, see you in a bit. Bye.